I think sometimes even if you don't like your grade on the first one, at least now you know what to expect, you know how your studying is, you can adjust from there. So, but if you need something from me, please let me know. I'll also say the tutoring center is fantastic, whether it's academic coach or sometimes in the physical therapy related courses, they don't have a lot of like content specific tutors. But if you need, I can always find some way to help you with that. So, but I'll be around after class if you wanted to look at it. This week you have a practice quiz, another quiz to do, just like the last one, right? 5 attempts, really designed to make sure you're staying on top of your studying. And we kind of get screwed a little bit in the spring semester because we have spring break. That's nice, don't get me wrong. But I hate having a spring break where there's some content and then a week off and then we get more content and then it's just an exam right away. I don't think that's good for anybody's education. So we're going to get another exam next week. It'll be our midterm exam, and then we have nothing hanging over our heads for the vacation. Have a true vacation. So we got today's content and all of the previous stuff. So it is cumulative. So if you did well on the exam, great. You've got a head start and you'll just brush up on whatever stuff you've forgotten the 1 week and then, take another exam and do well on it. If you didn't do well, it's a really good chance to relearn everything that you had just spent a lot of time studying. And again, come and talk to me if you need. All right, let's get into today's material. We'll come back to these objectives. So, expectations of healthcare. What's the big expectations of us? I think safety is the number one. I think if we look at those ethical standards, I think safety was an overriding theme in all of those standards. Safety, safety, safety. We talk about safety all the time. We talk about why laws are important, Practice Act. So safety is really big. Respect, I think, is another one. Informed consent. Do you guys have any other things when you utilize healthcare of any level? Do you guys have any other expectations you have? Be nice if it was timely. I think that I've always said, like, you can't run a restaurant how most medical offices are run. You'd be out of business in a month. No, my reservation was at 2. Yeah, I know it's 4 now. We're ready for you. Like I can't imagine. But anyway, so Patient's Bill of Rights is something else we've talked about this semester. I actually just had a new patient. I was going over their Bill of Rights with them, and I meant to bring a copy in. I forgot to. Maybe I'll remember to do that some other time. But I think overall, right to a competent healthcare worker. I think that's something that we all have the right to. Informed consent and the right to refuse treatment. We've already talked about informed consent. We'll talk more about it again. Privacy, that's that HIPAA law that we already discussed. Access to medical records is a lot easier now. With all of our electronic record keeping, patients can have access 24 hours a day, where in the past, when we had paper charts, the patient would say, I'd like access to my record. All right, well, now someone in the office has to spend, depending on how thick the file is, a couple of hours making copies of all this stuff. And there used to be a fee, like, it's going to cost us 10 cents per page to do that work. But now everything is really easy access. Right to safe and ethical environment, right to equal and non-discriminatory care. So prior to 1972, there was no such thing as informed consent, which is kind of crazy to think of. The medicine was a paternalistic model, which meant the doc was the decision maker and a lot of times the sole decision maker. Really heavy on the principles of beneficence, acting in the patient's best interest. So that was how medicine was conducted. And here's a little picture of that model. But over time, we've really evolved into this patient-centered approach. So the patient and their family is at the center, and then everyone else just like Knights of the Round Table, right? Where everybody's equal, everybody's powerful, but really it's that patient we're all trying to get better and work hard for. And you know, it replaces the doc as the decision maker and puts it on the patient. And informed consent, we've talked about already, but foundation of informed consent is a person's right to autonomy and self-determination. So the three legal components is it has to be voluntary. The person must be competent. What were some examples of where the competence of a patient can be questioned? There were two, I think. Yeah, what do you got? Any sort of cognitive impairment. And that has to be well documented, diagnosis alongside of it. It's not just us saying, oh, their cognition's impaired. No, it's well documented. I can think of one other one. I might be forgetting one, but I can think of one other one. Anybody got the other one? Pediatrics. Yeah, pediatrics is the other one. Yep. Here's another sometimes barrier. Who speaks multiple languages in here? We had a handful of people that did, right? Nobody speaks multiple languages in here? Oh. So consent is informed and given in a language that the patient can understand. That sometimes can be a tricky one. Now, hospitals have interpreters on staff. But man, it's really easy to have interpreters now. There are different programs, and the bigger hospitals have to use this, where you can just click on the language, and then a person is available 24 hours a day. These bigger companies, but I think for most of us, there's a million different types of translation apps that can help us. But again, the patient consent has to be informed and given the language that the patient can understand. So again, the informed consent includes the diagnosis or evaluation findings, recommended treatment, risks and benefits of that, risks and benefits of not having treatment, alternate treatments, and then the risks and benefits to those alternatives. So I think we've gone over that already. So advantages gives power decision making to the patient. That is an advantage. And anytime I've got a patient, this actually works well with kids too. Anytime you got a patient who's really resistant, if you give them a little bit of power, it'll go a long way. Especially, you know, as we age or get sick or injured, our decision making is less and less. Our power is less and less. We have less and less control over ourselves. So a patient sometimes starts, I'm going to say becomes difficult, but that's not the right phrase. They start saying no to everything just because they don't have the ability to make their own decisions, right? They're laying in the hospital bed and they can't get up for some reason. There's not a lot else that they don't choose who their roommate is. They don't choose what time they're going to eat. They don't even choose what they get to eat, right? So they've stripped their independence has stripped away. Sometimes they're just saying no to PT or other services just because it's a choice they can make. So giving our patient power to decide is really important. It also enhances clinician critical thinking. I've got to come up with these alternatives. You don't want to do squats today? No problem. I can do other things. We can do deadlifts. We can do bridges. We can do step ups. We can, you know, we don't have to do squats. We can do box lifts. Guess what box lifts are? Squats. You know, we get to call them something different, but sit to stands, right? That's a squat, just different. So it enhances our critical thinking and it really makes us decide, like, oh, do I actually want to do this or not? Disadvantage is time. How much time do you think it takes? It takes a lot. It takes a lot. Anybody ever work in healthcare of any level? Anybody? Yeah. Anybody ever been a patient? Probably everybody, right? How busy are all of those workers? I know I complain about the, you know, docs being on time for my appointment, but do they ever appear that they're just sitting around? No, there's always a lot of work, right? So you're going to feel that crunch when you need to see 16 patients in your 8-hour day. yeah, we've got to get going. We got to make this decision. I got to go. We got the next person coming. So that can be a disadvantage. The other thing is patient can choose the less than desirable option. Hopefully all the options are acceptable. But I think I've used the example before. Mom fell at home. The team is thinking you should go to a skilled nursing facility for a little while to improve your strength and balance. And mom says, not going. I'm going home. Okay, what's going to happen once you get home? We don't know, right? But the patient can choose that less desirable option, and then our job is to support them in the best way we can in that option. So we got a couple examples. 6-year-old recovering from total knee replacement, scheduled to begin outpatient PT. PT recommends manual therapy, exercise, neuromuscular reeducation. So the patient has decreased range of motion, weakness, difficulty walking. Recommended treatment, strengthening, stretching, and gait training. See some benefits, some risks. Particularly the risk that we try to, because anybody ever see someone after a total knee replacement, family member, or anybody else like that? It's painful. It's one of the more consistent and pain. The pain is not only consistent, but it's also severe. Yeah. Oh yeah, so he knows. Yeah, and you see it. For me, the rehab after total, the recovery after, not necessarily the rehab, the recovery after, it sucks. There's no way around it. It just sucks. And we're going to hold our patient's hands, we're going to pat them on the back, and we're going to say it'll be okay because it will, but it sucks. The thing that we have to convince our patients to, first of all, when somebody, I'm sure everybody's either had the flu and just doesn't feel like getting out of bed, or been in pain, some sort of injury at some point. Um, how fun is it to get out of bed and move and exercise when you're in pain? Sucks for us, and we don't even have anything wrong with us, right? Um, so getting our patients who are in discomfort to get them to do what we want is really tough sometimes. But one of the things with total knee replacement, man, if we don't move this leg with stretching exercises, some manual therapy, the risk is if the range of motion doesn't improve, this manipulation under anesthesia. So that what happens is if the knee isn't straightening particularly and also bending enough, the patient goes back to the surgeon. They get put under. They go to sleep. They get put under anesthesia. And then what do you think the doc does? Cranks the hell out of that knee. Now, don't worry, the patient's asleep. But guess who works with the patient once they wake up? Right? Um, Guess what they complain of when they wake up? Everything hurts even worse, right? So that is a big risk. Listen, I want to give you, listen, I understand your knee hurts today. I want to make it an easy day for you. But we can't give you an easy week because this risk of not making enough function and needing to go under anesthesia for it, that is a real risk. Plus, I don't know if anybody's been under anesthesia before. Some people have a really hard time for days and weeks after being on anesthesia. Nauseous a bunch, groggy for a while. Some people, it really hits them for a loop. So just being put under anesthesia sometimes is a big issue. Here's another example. 7-year-old with cerebral palsy, recommended for PT coordination and strength. Parent is hesitant about using orthotics. So something that can happen with cerebral palsy is a lot of tightening and a lot of, we call it spasticity, where their limbs are just like kind of stuck in a position. So one of the things we could do is orthotics, which are braces, right? Different braces to provide either stretching or just to keep the limb in a position. There are other things we could do. We'll look at it in a second. But because the child's a minor, a parent or legal guardian has to provide consent so that the child itself cannot. So we have our evaluation findings, recommended treatments, risks and benefits, and then the risks of no treatment. The alternative, serial casting is kind of fun because, if my elbow doesn't extend all the way. What you could do is you could stretch it all the way it can and then put a cast on it. And now that cast is going to hold it in that prolonged stretch. And then a week later, they cut the cast off, stretch a little bit more, put another cast on. Next week, cut the cast off, stretch a little bit more, put another cast on. So that's what serial casting is. What do you think? Just, you know, pros and cons of orthotics that would also do the same thing, right? Prolonged stretch over a period of time. Pros and cons of using those orthotics versus casting. If you had to use one of them, what would you choose? Give us some pros and cons. What are some pros of the orthotics? The bracing. Yeah, yeah, not completely stuck. What else? I think you can take it off. You can take a shower, right? You can go in the swimming pool if it's the summer. I wouldn't suggest it, even though it feels nice out today. Yeah, it can be taken off. Um, Fairly lightweight compared to the cast. What do you think some cons are to the cast? Yeah, so yeah, it's going to fix my arm in a very specific position. So now it's going to be a lot more difficult. Yeah. Actually, just think about dressing, putting on a t-shirt with the cast versus a brace. I can with the brace, I can have it off, put my clothes on, and then slap the brace on, right? So, give me some other cons to the cast. It's heavy. I don't know if anybody's been in a cast. They're heavy. What do you think if I've got a cast on my arm? What do you think happens to all the skin on my trunk eventually? Eventually, it's going to rub against and it's going to cause some abrasions. How bad it is depends on, I don't know, 7 years old. I bet you it's going to happen, you know, a decent amount. Um, so, yeah, if it was me, man, I'm choosing orthotics. What if we know the 7-year-old is very independent and the second we put it on, they're going to go in the next room and take it off? Now, what do we probably suggest for that patient? Now they can't take off the cast. So maybe for that kind of a person where you're just not going to wear it, yeah, maybe we do have to. And the pros then outweigh the cons, right? So being able to take off the orthotic is both a pro and a con, depending on the person that's using it. There's also Botox injections. Those just a neurotransmitter poison, basically, that just helps decrease the muscle contraction. There could be surgeries too. So if that's what our choices are, man, I know what I'm choosing between all of those. Another one, 75-year-old post-stroke. Cognitive impairments can communicate basic and understand basic information. Spouse is present and insist on making decisions. So now this is a tricky one. Now the patient has to be evaluated for their decision, that cognitive ability. Can they make their own decisions or not? And this one's really tough because I've had plenty of these patients. They understand basic information, but are they understanding what I'm asking? You know, that's not my decision. So we got to go find the psychologist to help us figure that out. So risk, then that's the big one for that. You can read the rest of the content there if you want. So what do we do to inform our patient care? Well, in your textbook, you have standards for PT practice. We also have laws. We've talked about HIPAA, Affordable Care Act, Americans with Disability Act. There's others as well. State Practice Act. We have our professional guidelines. We went over quite a bit already too. So all of that will help with our standards of practice. One thing that we should always think about is how do we get our patient to improve compliance? That's something that's really tough. Compliance for our patient is not only how do we get them coming twice a week If it's outpatient, how do they come here twice a week for the 6 weeks that we think they need? It's also when they're in the hospital or nursing home, how do they not say no? Like we have to give them the choice to refuse treatment. But how do we get them to not refuse treatment? Even though we're giving them that choice, right? But compliance is also wearing the orthotic, like we just talked about. It's also performing your exercise program. Guess what patients hate doing? Doing their exercise programs. How do we improve their compliance of it? One, the perception that the clinician is competent. That's the first thing. So a lot of times I say our work is both a science and an art. If we were to go back to informed consent has to be in a language that the patient understands. I don't speak any other languages other than English. But I think language that patient can understand also means medical language is tough. You guys that are taking med terms, are you learning a bunch more terms that you never knew what they meant? Yeah, that's a good. I can see you're enjoying that class. Yeah. Yeah, medical language, it is tough. What I think it's 2/3 of Americans have difficulty understanding basic medical advice. So you guys, just by being in this class and taking med terms, right now you're ahead of, almost 70% of the entire country, just because you have just a little bit of knowledge. Never mind all of it that you're about to get. So when I say perception that the clinician is competent, and the language, we want to use terms that our patient understands. If my patient doesn't understand gait, what do I mean by gait? Walking, right? So if I say I'd like to do gait training, if my patient doesn't understand what gait training is, but they speak English, they have cognitively intact, I need to change my language around. I'd like to do walking training with you, right? I need to change that. However, the art of it, perception that the clinician is competent, you don't want to dumb down your language so much that they perceive you as dumb. That's really tough. So sometimes I use both words on the medical terms. We're going to do some gait training. That means we're going to work on your walking, right? So that's how sometimes I can prove that I'm intelligent and competent, but also make sure my patient understands me. But that is definitely something that I battle every single day. What term am I using? I'm in general a pretty relaxed, easygoing clinician. I have some clinicians. Um, Hi, Bob. Ian is his name? Oh, yeah. Right? Does he introduce him? What's his last name? Yeah. That's right. Does he introduce himself as Dr. Manning? No. I believe, like, I think he's trying to that. Yeah. Oh, who's the other PT that's? Did either any of them introduce themselves as? Yeah, it's fascinating. I'm the same way. I don't say I'm Dr. Claire. I say I'm Josh in the PT. What do you need help with? And let's work on that. But I think that is something that we can improve our patients' perceptions potentially if we start using those terms. I know some people in high bar do. How about when you schedule the appointment? Does the front desk worker say, "Oh, you'll be with Dr. whatever"? It depends. Yeah. 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 Absolutely. Yeah. It's a tough one. It's a tough one. And that's what I mean by about science and what do we want? I would much rather make that connection with the patient rather than, I think we talked a little bit before about the barriers from patient to clinician, and as little as sitting at the same eye level with your patient. I think sometimes the titles can be a barrier as well. But anyway, the perception that your patient is competent is a tricky one because that's patient perception. That's not necessarily ours. And a lot of times I am, like I said, I'm easygoing. Um, I think sometimes the patients look at me and go, "What the hell is this guy talking about?" I don't know. I look around the room and I think I also see that look on some of your faces too. Um, the next one, perception that the clinician is caring. And this is going to go opposite with the titles that we were just talking about. This can be in conflict with the perception of competence. When I say my name is Josh, there's a deeper connection than if I were to say I'm Dr. Claire. There's just a little bit more coldness that when we put those formal titles in. But clinician is caring. How do you guys think we show that our patients are caring? I mean, that we are caring of our patients. I think we do it all the time. And I know you guys, even if you're not, I know you're working in the clinic now, so you're working at the nursing home now, right? So I know you guys probably have it already, but you guys that maybe not don't have that type of patient experience, I know you guys are going to demonstrate that you're caring. You did it with me on day one when I took your class. How do you demonstrate that you're caring? Yeah. Yeah, yeah, yeah. Just really try to make that connection and beyond just like the knee that we're working on. Tell me how you're doing. Yeah. Any other ways? You got. I think listening is probably the number one tool that we have. Listen to what they're saying. I think ways that we can get distracted from showing that we're listening, doing our documentation as we're working with a patient. That is something that I don't get me wrong. I do my documentation with my patient. I don't get paid to do documentation at 8 o'clock at night after I put my kids to bed. I get paid to do my documentation with my patient. So I still do that. But man, I've got to really balance the art of listening and being engaged versus I know we've all been to a doc's office that don't even look up from their computer, right? Um, so yeah, listening I think is the biggest one. You know, connecting with them on a level beyond just what we're working with is the next one. I think you know, other ways that we do it. We show up on time. I think in the Northeast we're very time conscious, so that's something. Being appropriately dressed, I think, is something, and especially with my patients. You know, most of my patients are older. I've got to look okay. I don't have to look perfect, but I've got to look okay. Um, yeah, all of that matters. Yeah. Oh, you do? What do you do there? Yeah, 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 yeah. I bet you're the favorite person just because you do that. Yeah, 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 yeah. Perfect. I bet you're the favorite person when they come around. They say, "Oh my God, there he is. Let's go, let's go. What are we eating today? What nursing home are you at?" Oh yeah, 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 yeah. That's nice. Nice. They do a good job there. Yeah. Um. Yeah. All of those things matter. They really do. And I think how many people are interested in this field and decide to take this class because they like people, they want to help people, right? So I think for us in this room, a lot of that stuff comes naturally. Where I think I know plenty of brilliant, I know one orthopedic, brilliant shoulder surgeon, has a reputation for having a less than positive bedside manner. Um, I don't care, fix my shoulder. But he would be a terrible PT. He wouldn't. He couldn't hack it. Even if he knows all the extra, he would not. I'd have to fire him. Excuse me, doc. You're absolutely brilliant, but I gotta let you go. Yeah. Yeah. It's a necessary thing for us, different than other healthcare workers. Your anesthesiologist, they're going to help you count back from 10 to 0, and you're going to be out by the time you hit 7. You know, they don't need to have great bedside manner. Yeah, we do. And then the power of patient-centered decision-making. I said it earlier, you want to get your patient to do something, give them the choice to do something. And informed consent is the way to do it. And they'll make the decisions. Ironically, they'll make the decisions we're hoping they're going to make if they think we're competent and caring. And you know, it actually gets a lot easier. So then, practicing within the PT, practicing physical therapy within that patient bill of rights. So we are legally responsible for obtaining informed consent. And actually, we document it in our notes. Talk about documentation at some point. Sure. Yeah, we document it. Patient educated with informed consent. Patient agreed to this treatment. It doesn't have to be every single day. It's really just the new time. So, hey, you're doing great with your exercises. I noticed that you're not having any trouble getting up from the chair. I would like to switch this to a different exercise. Would that be okay with you? I think it'll be more challenging. It'll help you get stronger faster. So it just has to happen when there's change to the treatment and when there's something new, I should say. And patient care provided by PTs and techs must be supervised by the PT. PT has primary responsibility of overseeing that patient overall, with those PTAs being those clinical-based problem solvers. And what type of supervision do techs need? Aides? Direct, very good. Other ways to manage patients within their Bill of Rights is set realistic goals. I'm a bit of a dreamer. I tend to set really high goals, and bit me in the ass every now and again. But I think that's something that's really important because, man, if I tell my patient we'll get your pain better in 3 weeks, and in 3.5 weeks they're not better, boy, that's a problem. Actually, I'll tell you one thing about setting realistic goals. So Disney World, greatest customer service in the greatest customer service business in the world is at Disney Park. When you're in the line of a ride and it says, "Oh, it's 55 minutes from this point till you get to the ride." When you get to the ride and it's your turn and it's 50 minutes, what is your feeling? Happy, great, wait, we beat the clock. If you get to the ride and it's 60 minutes, what are you? Oh, come on. You said it was 55 minutes, right? Those signs in Disney World, they know it's not going to take you 55 minutes. They know it's going to take you 50 or less. Like they're pre-setting, they're setting realistic goals. Hey, if we tell them 50 minutes and they get there in 40, they're happy. If they get there in 51, they're pissed. So that's something that I think in physical therapy, I personally can do a better job setting those realistic goals. All of great example that I run into is I have patients say, "Oh, I'd love to drive again." Okay. When was the last time you drove? 6 years ago. All right. I'm not sure I'm the one to be talking about this. But I say, listen, from the physical therapy point of view, we need to get up out of a chair, walk to the car safely, get in and out of a car. That includes swinging the door and not falling down as the door swings open. We need to get in the car. And in addition to all the coordination, we need the leg power to stomp on that brake quickly and stomp on the brake with adequate power. That way, if there's an accident about to happen, you have the physical power to stop your car. Those are the things I can work on. Whether we get to driving or not, that's not my decision, but we can work on all of those things. Do you want to work on that? Great. So that's how we would set a realistic goal and also listen to the patient and then use that to enhance what we want. Having a good support system, not only with us and the rest of the team, but also with the family. Patient protocols to establish uniform standard of care can sometimes be a really good thing, although I have some complaints about that. We shouldn't be wildly different. We shouldn't treat one ankle sprain wildly different than the other. But I think I'm going to treat my dancer a lot different than my baseball catcher. Like those are two different people that should have some differences. And where I think we get in trouble with protocols is when everybody gets the same thing every single visit. I don't know if we're really using our brain that way. But anyway, and then demonstrate and document competence in patient procedures. Continuing again, we talked about a bunch with that as well. Fairly and accurately representing our capabilities. I had a really good friend. He runs he's actually one works at High Bar. Dave Pavo, have you come across him at all? Yeah. Okay, yeah. So he's geez, I don't know what his official title is. Pretty cool guy up at High Bar. He called me for a patient. He said, Josh, I got a friend, they need home care. What do you think? And I've known Dave for 20 something years. Dave, I'd love to help you with it, but I want to help you, Dave, but I'm not the guy for you. So fairly and accurately representing your capabilities. Conducting business in compliance with laws, rules, and regulations, adhering to ethical standards. Disclosing any financial incentives is important. We don't get into trouble with this a lot. There was a point in time when this was a huge problem in healthcare, especially when it came to medications. Part of the opioid crisis happened because some docs had financial incentives to prescribe Oxycontin. You're our top provider that you wrote so many scripts. We're going to give you an extra $10,000 this quarter. Great job. All right. Well, I don't really want my medical decisions lining your pockets. Like I'm already paying you for the visit. Like this doesn't feel right to me. In the physical therapy world, we have very little of that, although it can happen. But we really don't have a lot of that. Documenting thoroughly and accurately, clarify all situations that may appear improper, illegal, or unethical. I had a recent example of something that I'm trying to think of. What was it? I have a patient right now. So with home care, we have two very specific jobs. Have them functioning safely in their home, and then get them to able to be in and out of their home. This woman broke up a while ago. She has a really, really heavy door to her apartment building, and it doesn't have one of those automatic openers. She physically could not open the door and maintain her balance. Like she couldn't navigate with the walker, her balance, the heavy door. She weighs less than the door does. Like it's a big thing. She's been able to do that the last two visits. Awesome. Medicare, which is her insurance, covers home care 100%. When she goes to outpatient, she'll owe 20% copay, which is less. I think it's about $20, maybe a little less. All right. Well, does anybody here want to pay $40 a week when they are already paying zero? And they don't have to leave their house, right? So she is resistant to me discharging her, even though we've met our goals. She's by definition no longer homebound. She does not qualify for home care PTA. That is an improper situation for me. Patient saying I don't want to be discharged. I like her. She's a nice lady. She's right around the corner from the Newport campus. So I work and then I go see her and then I go home. It's a beautiful setup for me, but it's improper. I don't know if improper is the right word for it, but it's unethical for me to continue to see her. No, we met our goals. I cannot be billing Medicare for home care when she's ready for outpatient. She is no longer home. Don't make decisions that collide with professional ethics. Example of that is cutting costs at the expense of quality. address patients' concerns and resolve conflicts quickly. We don't have a lot of those, again, because we do such a good job about caring with our patients and connecting with them. We don't have a lot of those conflicts, but we do work with a lot of people, and eventually some conflicts will arise. This happened to me early in my home care phase of my career. I had these husband and wife couple, and elderly, and they really couldn't take care of their home. Like their daughter worked and lived in Maine, and she would come by Friday to Sunday. So every single Friday, she'd leave work. I think she was a teacher. She got out like 2 or 3. She'd drive. She'd arrive at 7 or 8 at night, and then she'd leave Sunday evening to go back to Maine for the week. So there were times when they couldn't take out their trash. If they had trash that was full, it would be in their pathway of walking. Big fall hazard. So I said, listen, I'll just take this trash out. And then one day they had a light bulb burnout. And it was Monday or Tuesday in the week. Well, not being able to see, especially when there's trash littering your pathways, that is a huge risk. So I said, you have a light bulb? Yeah. All right, let me change the light bulb for you on my way in. Right. How long? I'm already walking out. Taking the trash out requires no extra work, although if I ever got hurt, my boss would kill me, because why would you be taking, like, I don't pay workers' comp to take out trash, Josh. Same thing changing a light bulb, but I think that's one of those ethical versus legal. Like, I'm not supposed to be changing light bulbs. I'm not getting paid to change light bulbs, but I also can't leave their house knowing that they're at a higher risk for falls because they have a light bulb around. Anyway, I got there the next week, and they wrote a list of tasks for me to do around the house. They said, we don't want PT today, but we have a leaky faucet in the bathroom. We also have the lock on the front door needs to be tightened. And I'm like, okay, hold on. This is not, like, I'm not coming over to fix up your house, although I do enjoy it. Would rather do a bunch of squats. So yeah, it turned into a conflict because me being generous with my time and capabilities, they started to take advantage of that. So that needed to change. So informed consent also gives the patient right to refuse treatment, right to refuse any treatment. And like I said, in the nursing homes and hospitals, this is a really difficult task. Other than Cedar Crest, the food sucks. What do you think about the food at Cedar Crest? What do you think about the? It's good, but it's just because they're. Yeah. Yeah, right. We can't. Yeah. Yeah, I think that's when you're in a nursing home or a hospital, okay is about the ceiling. Like, what about your place? Yeah, nice. Yeah. Okay, yes, that's a little bit, but yeah, I think with the yeah, but I also you bring up a good point. We have so many patients on so many food restrictions, whether it's salt or fat or sugar. Like it's tough to make a nutritious meal also taste good within the confines of what we've got to do. So in the hospitals, our patients aren't eating well. They're not sleeping well. Anybody ever try to sleep in a hospital or a nursing home? Loud all the time, right? I mean, the beeps, alarms, announcements over speakers. The night shift nurse. When my daughter was born, we stayed overnight in the hospital, and we were right outside the nurses' station. And all night long, those nurses, man, I'm glad they were having fun, but just shut up and let me sleep for a minute. Like, so yeah, they're not sleeping well, they're not eating well, they're in some sort of discomfort. And we come in and say, hey, would you like to get up and do exercise? Let's have fun. Let's have some fun. And man, it's tough. To get them to participate sometimes can be really tough. But the right to refuse treatment is part of informed consent. Competent patients have the moral and legal right to refuse treatment, whether it's life-sustaining or not. Refusal is always an option. The life-sustaining matters to us across all practices in physical therapy. Yeah. Yeah. Yeah, if a patient, so a specific exercise and also the treatment as a whole, I have the same approach. Tell me why. What's going on? And maybe what they had for breakfast isn't sitting in their stomach, and maybe I can see them right before lunch. Maybe they just need an hour to digest. If it's a specific exercise, well, tell me more. What else is it? Because if I've done a good job with informed consent and I've demonstrated my competence and also demonstrated that I'm caring, it should be easy, you know? So if it's a specific exercise they don't want to do, great. Here's why I think that exercise is important, because we're accomplishing these 2 or 3 tasks. What don't you like about it specifically? Well, my knee hurts when I do. Okay. So maybe I can rearrange the order of my treatment to decrease the pain. That way the treatment can, that exercise is no longer painful. Maybe I need to change the height of the sit to stand exercise. It was a little bit higher of a chair, less of a problem, right? So I need more information other than no. No is, to me, an incomplete answer. Give me the rest. Tell me more. I had a terrible night's sleep. Okay. Sometimes in the inpatient world, they'll have the patient schedule on the board too, like on a whiteboard. And if I look at that schedule, I say, listen, if I get out of here right now, you'll have an hour of rest before OT comes in at 11. You have nothing at 3 o'clock. Could I sneak back in at 3 o'clock? Like, if I give you rest now, do you think that would be okay? Like, so that's all. Like, there's always another solution. Um, and here's another one. This is um, you guys might handle this differently. When I was in Hawaii, being white in Hawaii, I didn't realize this, a little bit of an issue. Not exactly the friendliest people to the white people. That was a bit of a culture shock for me. I had this one patient, she refused to work with me because I was white. She needed to wait for my Hawaiian boss. He's not going to be in for an hour. Like, you want to just get this done? No. Well, what if I just did? No. How about I just do this part and he comes back? No. Okay. Okay. So yeah, that's the right to refuse. And she refused to work with me. It wasn't an aspect of treatment. And you know what? Who is it? Is it, she wasn't treating me badly. She wasn't calling me names or anything. She just said, there's no effing way I'm working with you. Okay. I can't make you. And we got someone else that you feel comfortable with. Actually happened earlier today. The patient wanted a female clinician. I have a PTA that's a female. Can I do the first eval and then you work with a PTA? Is that acceptable? My female PT comes back she'll be back next week. What would you rather do? Delay care or get started and for one visit? So we give that power to the patient. So it just depends on, I need more information than no. Yeah. That answer your question? Okay. So again, all across all settings, we need to know more about our patients. Advanced directives, it comes in really important as we work with more older populations. You guys that are in the rehabs, do you have on their doors, do you have something that says like do not resuscitate? But you don't have that, do you? Sure. Sure. So those are different precautions. I was talking. Okay. Okay. Um, so it's important for all of us to understand that. It will come across in our lives, and especially with me working in geriatrics and in home care. I mean, there is a chance that I will arrive for my patient's visits and that person will be on the floor. I've got to know what their expectation is. So advanced directives are used by mentally competent people to identify specific decisions regarding medical events in the future. It can include a list of desired or undesired medical interventions. Identifies a person designated to make their healthcare decisions should they become incompetent, which is called a durable power of attorney. So that is an individual who acts as the durable power of attorney, cannot be a healthcare provider or an employee of the patient's healthcare provider due to the potential conflict. So this person is going to make all of those healthcare decisions for that person. If there is a cognitive impairment, then there should be a POA, and then we're going to get all of that paperwork and we're going to see it. But again, if you work at, Rhode Island Hospital, you can't be that power of attorney if you use Rhode Island Hospital with this person, because now there's some potential for a conflict of interest. A will is for someone who is terminally ill. An example of advanced directives, which the competent person expresses their wishes regarding medical management. Legal documents signed by the patient in Rhode Island is used to express the termination of life issues. Shortcomings of written wills applicable for only the terminal ill. Limitations of what treatments the patient can refuse. And here's the thing that healthcare provider who does not honor the document. So, I can't remember every single person's advanced directives that I see, but if I come to a patient and I find them on the floor, my job is to act and not say, oh, let me pull up the chart and see if they have that form signed. Like, act and then we'll figure it out later. But it does provide a little bit of a sticky situation. Healthcare providers may interpret the document incorrectly and provide treatment that the patient would not desire. Works best when there's a durable power of attorney as well with it. So in 1990, President Bush signed the Patient Self-Determination Act, which requires hospitals and skilled nursing facilities to develop written policies regarding advanced directives as a condition of payment. Facilities are required to ask patients if they prepare those documents. I have to do that as well in the home care world, so it's not just. And then there has to be some sort of written information for the patients as well. In some states, this does not apply in Rhode Island, but in some states, if the patient lacks advanced directives, then someone else can make decisions. And it's in this is the order. So first is spouse, then an adult child, majority of reasonable available children, then a parent, then another surrogate decision maker identified by the patient, nearest living relative, and then clergy if there's nobody else. So, they've been going to my church for 30 years. I'm going to make their decisions on. They got nobody else in their life. That person can. Euthanasia is defined as the action of inducing painless death. Active euthanasia is deliberate. I don't know if anybody's heard of Dr. Jack Kevorkian, who's known as the suicide doctor. He would go in and administer end-of-life medications to the person. The big problem with it is it's contrary to the Hippocratic Oath, do no harm, right? So that is the major controversy with that. Passive euthanasia means letting the patient pass for lack of treatment or suspending life-saving treatment. Do not resuscitate is an example of that. Removing the respirator, somebody needs a breathing machine, removing this heart and lung machine. That's what we mean by that passive. Just we're not going to do the life-saving methods. I actually had a patient just recently. I saw him walking on for years. He, when he was 20, he was a roofer and he fell off the roof, had a traumatic brain injury, and was essentially comatose the rest of his life. I saw him off and on for about 5 years. And his family made the decision when he was, I think, was he 45? He's just a little bit older than me. That they're going to then change his care plan and their decision making. So they made him a do not resuscitate. Couple weeks later, he got a urinary tract infection and he died from a urinary tract infection because the life-saving treatment for him would have been antibiotics, maybe up to the level of an IV line antibiotics, but that's a treatable thing. But we made the decision just a couple weeks ago. Like the family was kind of surprised that, oh my God, we just made the decision. We weren't, even though we made this decision, we're not ready for it right now. So it was really tough for them. But that's one that happened just he passed just a couple of months ago. Do not resuscitate includes CPR. There should be that DNR in the patient's chart, and it should be. That's what I was asking you guys if it was visible or not, because it needs to be like needs to be really obvious. Responsibility of the healthcare provider know if the patient has it in the chart. Consequences, well, none. Although there could be some ethical violations that we'd have to answer to. But for the most part, there is no consequence for ignoring a DNR, which makes it really complicated for the family. One thing that, especially as I work with geriatrics, learning how to deal with patients' passings is something that's really tough, and you've seen that already. And how about you? Have you seen that already in the Cedar Crest as well?
Well, yeah.
Right. Yeah. Yeah. It's tough. It's tough. It's tough for the whole staff. It's tough for a lot of people. Important to discuss and acknowledge your feelings. A lot of facilities have support groups. And I think it's such a bittersweet call that I get from this. Happens to me a few times a year, where I'll get a phone call, family member of somebody I worked with, and they'll say, "Hey, mom passed, dad passed. Want to let you know, thanks." And it's funny. It's kind of bittersweet for me most of the time, because a lot of times I get thanked like, "Hey, they were able to live in their home until the end because of the work that you guys did," and it's really bittersweet. And actually, I had this guy. He had ALS, and his brother lived next door, and one of his favorite things was to go to his brother's house, make fun of his brother, because if you have brothers, that's just what you have to do. And also play with his brother's dogs. His brother had 2 dogs, so he would go over, let the dogs out, play with them a bunch, plus his brother's chops, and then go home. And one of the PT sessions, it happened to be a beautiful day. I said, "Let's go. We're gonna go." He passed away a few weeks later. It was the first time he had done that in months, and it was the last time he was able to do that. And while it was really sad, what's the whole purpose of PT? To improve mobility, to enhance quality of life, right? And enhance the human experience. And man, didn't I get the chance to do that? So it was really bittersweet. But yeah, it's still sad. It's still really sad, and it can really throw us for a loop. So it's important to for us to take care of ourselves and to also take care of our coworkers. It can be really, really draining. I think one of the other things, one of the beauties of our PT world is how we get to connect with our patients. We've talked about that a lot today. We've talked about that a lot in this whole semester. The tough thing is we get to really connect with our patients, and it can be really heart-wrenching on some of these things. Yeah, yeah, yeah. Oh, yeah, really tough. Who did? Really? Yeah, yeah. Yeah, really tough, really tough. Um, yeah, yeah, I don't have anything. It's not easy, that's for sure. So that's it. Let's bounce back to these objectives. I utilize ethical standards of ethical conduct for the PTA to identify acceptable standards. So we've talked about professional competency and the ethics of it with those three documents way too much. Informed consent and provide examples include PTs and PTAs. So concept of informed consent gives power to what? The patient, and there's a few major elements that includes. What are the major elements? It's got to be voluntary. The patient has to be competent and within the language that they need, that they can understand. Yep. Three components of informed consent. Oh, we'll go examples after. Three components, at least three. What are they? Evaluation findings. What else? Treatment options, risks and benefits of those, and then alternative treatments and risks and benefits of those. Those are all the components. What are a couple of examples that we talked about with informed consent? Remember any that we covered earlier? Think we had one. The one I think we spent the most time with was the 7-year-old that needed either orthotics or casting. That was the big one. Key concepts of patients' rights and identify appropriate behaviors which demonstrate support of these rights. So what were the key concepts of patient rights? Next one here, right? Right to safety, respect, informed consent, competent healthcare worker, privacy, access to medical records, safe and ethical environment, equal and non-discriminatory care. Um, advanced directives. That's end of life decision making, certain treatments to not do or to do. Power of attorney is the decision maker, the legal decision maker. And then active versus passive euthanasia. All right. Any questions? So I still have to, I hope to have that practice quiz done today. If not, it'll be done tomorrow. So you have the practice quiz to do, and then we have our exam next week. Exam is this material and all of the other stuff we already covered. Okay. Yeah, it's all the same. Yeah, yeah, yep, yeah, just adding this other stuff, and some of this stuff is overlap with other stuff we've already had. So I haven't written that exam yet, but yeah, right around that. Okay. Yeah, stick around and I'll show it to you. Okay. All right, anything else? Yep. Somewhere around 50. Yeah, it's worth a little bit more, so I try to make the midterm a little bit longer. But yeah, somewhere around 50, between 50 and 60, I would say. All right. No problem. All right, guys, reach out if you need anything, okay? Good luck studying. Uh,